Good. Hi, everybody. This is my name is Steve Wright. I'm a clinical professor at the UAMS South Central, and we're going to talk about transitions of care in general, and specifically our experience with transitions of care over about the last 6 or 8 years. Um, I'm going to be assisted today by Autumn Brown, our PharmD, and Tanya Hawkins, our RN, who is our clinical coordinator. And at some point during the presentation, I'll introduce you to our whole staff. Because as we found as time has gone on, the staff requirement to actually manage all of the variables involved with transitions of care has actually gotten larger. We've done a little bit better job, but there's still work to do. And the challenges I think that we face are uh, applicable in any of our clinical settings. Our first thing is our agenda. And what we want to look at today is to examine the link between transitions of care and readmissions to the hospital. We're going to,
Dr. Wright,
yes.
I'm sorry, your slides are not showing.
Oh. What about now?
Not yet.
Okay, come back in here. How's that?
That's good. If you could go to display settings
Okay.
and click that, and yes, perfect.
Okay.
Perfect.
Very good.
Thank you.
So we'll go back to our agenda for today is to examine the link between transitions of care and readmissions, to review the transitions of care codes and billing codes, discuss the steps to establish your own TOC program and modify an existing program, kind of based upon our experiences and our lessons learned. We're going to review our UAMS South Central model and discuss the opportunities for improvement. Introduction to transition to care. Transition to care is that bridging step between moving patients from one clinical setting to another. And initially we got focused on this between the acute care hospital and then back to our clinics. But it also applies to from the acute care hospital to the nursing home, or from the nursing home to another nursing home. Any facility where we're providing healthcare, and then we have to transition that care into another setting. That process is fraught with potential for error. And when we have potential, when error exists in the patient care transfer, then we have potential in that setting to have morbidity and mortality that is preventable. Just in general, our readmission rates from the Medicare data showed that about 20% of Medicare patients had a 30-day readmission rate. And if you go to the bottom of the slide, you can see that estimated cost was about $26 billion a year. We've listed some of the things that are potential problems or potential errors in that transfer of care, namely diagnosis, adverse drug events, worsening symptoms. And some of these things are preventable, but some of them are not. I don't know that we can prevent somebody getting worse in most of our chronic medical illnesses, but things like drug reactions, mislabeled diagnoses, and those kind of things are things that if we're diligent, then we can decrease the morbidity and mortality that are associated with errors in that transfer. This started with the Affordable Health Care Act in 2010 is when it first came to our attention. And the thing that happened here first was that in 2013, our local hospital, Jefferson, asked us to look at our readmission rates for congestive heart failure. And we started our process just by using that single diagnosis. And we were able to talk to the IT people at the hospital who were able to then give us the data on our 30-day readmission by the attending. And so the residents come and go, as you all know. And the stable thing, the thing that is most consistently trackable, are the list of attendings. We looked at that for congestive heart failure as our initial phase of our transition to care program. What we found is that, going to the next slide, what we found is that a lot of our problems were related to communications breakdown, problems with patient education, and accountability problems. We'll talk about each of these specifically because each of them involves a little bit different detail. The consistent factor being that is that we have to consciously pay attention to each of these details if we want to affect the data in the end, and then ultimately mortality and morbidity. A big problem, I think, here, and it's probably exists in other places too, is the culture of this lack of a handoff, and I don't like to call it respect. I think there are some structural changes to our system. What we noticed is that in this transition in healthcare, some of the primary care providers were no longer coming to the hospital and providing inpatient services. And the primary care doctors were primarily staying in their offices. And the hospitalists were then becoming the people who were responsible for the care in the hospital. The primary care doctor was then lost touch with what was going on with the patient while they were in the hospital. And so changes that were made to the medication list, the change in diagnoses, the new echo, the recent stroke, the recent MI, all those things were not accounted for when the patient returned back to his primary care visit. And so there was a gap there between what happened in the hospital and then what happened back in the primary care setting. And so some of our initial attention was then focused on that. And it was not only in that we had primary care providers who were not part of our group, but sometimes there are primary care givers that weren't even part of in this county. And so since this is a regional hospital, we tended to get patients from as far away as Louisiana. And when we transitioned that care back to the person, say down in Crossett, that presented obstacles for smooth transition and the minimization of mistakes. There's an acronym here, SBAR, which talks about the situation, the background, the assessment, and the recommendations. But I think that is something that we all kind of intuitively know. But structurally, with the changes in healthcare, we weren't doing it as efficiently as we should. Communications breakdown continues with, how do we get that information about the acute hospitalization back to the primary care guy? In our case, for our group, we could optimize that by making sure that we had good discharge summaries and accurate discharge summaries, and that the discharge summaries were done on time. Part of our institutional problem is that the youngest person of the team is usually responsible for doing the discharge summaries. And so early on in an academic year, you're asking a person who's been a doctor 2 or 3 months to do a complex discharge summary and then send it to somebody in the clinic and then have relevant information for care going forward. And so there are some structural things that had to do with us transmitting information from the acute care setting into the clinic setting that had to do with, the distribution of work, the training of residents, overlapping of attendings, and those kind of things. And all of those issues were issues that were identified early on in our transition to care program. But also you have to come up with remedies for those. So it's one thing to identify where you have a deficiency, but it's something else then to institute a program to identify the deficiency and then have some remedy. The next big one is med reconciliation. Because frequently the medications get changed so much in the hospital that they might not have any resemblance to what the primary care doctor has down on his med list. And particularly if there's been some new event, i.e. CHF, acute MI, CVA, et cetera, that require new therapy. So again, within our group, it became a focus for us to look at med reconciliation in addition to discharge. To say nothing of that guy who's down in Crossett, who his patient ultimately got sent here to Crossett, he got taken care of at Jefferson, and how do we get that information into his hands? This is the patient education piece of this is a little complex in that Southern Arkansas has a high percentage of people who have a relatively low healthcare literacy. And so even when you do make attempts to explain some of the complex medical issues, it becomes an issue of their comprehension and then the provider's ability to bridge that communication gap. Not all people are equally talented at breaking complex messages down into very easily understood language. And so the healthcare literacy and the transmittal of healthcare information in a pertinent way is a problem and will continue to be a problem. Again, I think these are things, it's one thing to identify a issue, but it's the second thing is to what is your remedy? And we'll continue to have that challenge. And I think we will continue as a group, all of us, continue to look for solutions. This is another obvious one. For us, we are the primary care team, but we rely heavily upon all the specialty services. And so the problem is not only with communication with the primary care team, it's communication within the specialty services themselves. Pulmonary will make a recommendation, cardiology will make a recommendation, nephrology will come behind that and want to change that medication. Then they'll ask the intern to discharge. And so the intern or the house staff, whatever level that is then kind of caught between, well, the pulmonologist wants this, the cards guy wants this. And so those again are issues that relate to communication of what our ultimate goal to be. We don't want to necessarily put the house staff in a position of being autonomous without having the benefit of getting of the specialty services. But we recognize that that is an area for potential problem. I think we're fortunate here at AHEC and all of our AHECs because we continue to get our people at the bedside in the hospital. And so they're playing an active part in the hospital course of some of our patients that have particularly chronic illnesses. Unlike sometimes out in the non-academic world where you have primary care providers who aren't necessarily affiliated by group, the transmission of that information can be more complex and more cumbersome. I think that we're fortunate in that AHEC South Central, we have a definite pool of patients that we're responsible for. And we have a definite pool of doctors who are responsible for taking care of them. And so our ability to transmit information amongst ourselves to take care of this designated pool of patients puts us in an advantageous position relative to some of the other guys who don't have that. And I think that our transition to care program is trying to optimize that opportunity. So what that involves with the primary care team is, coordinated care coordination services, proactively reaching out to patients, answer questions, confirm that they understand the post-discharge instruction, have the necessary medications, and coordinate the follow-up care. As part of what we do here with our inpatient service is that we have a multidisciplinary rounds every day. And so that we talk to the social worker, the discharge planners, the pharmacists. Pharmacy is part of our team. Behavioral health resources are available. And so every day in every inpatient, we have a multidisciplinary meeting where we try to discuss these factors, including, discharge, disposition, DME, transportation, medications. One of the things that's worked well for us recently is that our local hospital has instituted a meds to bed program where some of the medicines which had been previously unaffordable in some cases are now affordable through the, what's in it? 340B program. And so we have 340B going through our hospital pharmacy. And if our physicians write a prescription that's covered under the 340B program, we're able to get medications into the hands of the people who need them. I'm old enough to remember when, medications were not covered under Medicare. And I'd see patients who had high blood pressure and diabetes who couldn't afford the medication. And so even though we identified what the problem was, I didn't have any way to fix that if I couldn't put medication in your mouth. And so the availability of some of these new programs at least allows us to get, if not your primary choice, a good secondary choice, generic choice into the mouth of the person who needs to take the drug. This last slide, the redesigned clinic flow, is cumbersome, really. In that we have made changes, and I suggest that everybody makes changes to accommodate that flow that's coming from the hospital. Appointments have to be available if you want to see a post-discharge within 7 to 14 days. The hospital can't call the clinic and say, we don't have an appointment for a month. If this is a transition to care appointment, those appointments have to be available and in some way designated as a transition to care appointment. Because what we've done here is that we've increased the time slot available for the transition to care appointment. You can't put a CKD3 with an EF of 20% in diabetes and a bad foot in a 10-minute slot in the clinic for a follow-up and expect anything meaningful to happen. And so unless you have that designated time to get, number one, get the patient in, and number two, get all the associated healthcare records that were associated with that hospitalization into the hands of the provider, then you've lost an opportunity to ultimately decrease morbidity and mortality. For the sake of the admin side of it, you've lost the ability to have an effective transition to care visit, and we'll talk about the codes in a minute. But you have to have, there are some structural requirements of your clinic system that in order for you to meet the requirements of billing for a transition to care visit. And if you structurally have not prepared to optimize that, then I don't think that we'll be able to effectively take care of some of how that program has been incentivized by CMS. CMS is incentivized for us to have good TOC visits because they don't want to pay for readmission. And so they want you to see TOC, they want you to have a good visit, and they want to have good outcomes. Interactive contacts. Post-discharge, we have a program in the TOC program in general, as outlined there's a CMS guideline that gives broad recommendations for how we should construct the program. But contact with the patient within 2 days of his discharge is a fundamental part of that. And part of that contact is to make sure that, one, the patient picked up their medication. Number two, that they have transportation to your visit. Number three, are they clear about their visit? And if the second line of this is that if you don't make the contact, you should document that you've had at least 2 attempts to contact the person. Now, on our end, what we find is that contact information is variable, and that people move very frequently, but they don't have updated contact information. So we'll have one address in the hospital and a different address in the clinic, and the person might actually live at a third address. And so part of that contact post-discharge sometimes is difficult because we have to then kind of close the loop on all those variables. the face-to-face visit. 7 to 14 days, and kind of at the discretion of the discharging team or physician, to review the discharge information, to assess the need to follow up for any labs or tests that were run in the hospital that were not finalized prior to the discharge, to specifically interact with the other healthcare professionals. And I mean by that, the cardiologist, pulmonologist, the surgeon, the nephrologist. So you came back to me first, but you were in the hospital for your acute on chronic heart failure, reduced ejection fraction. I'm messing with your Lasix and your beta blocker. What does the cardiologist think about this? How do we make sure that he gets back into that groove, so that we make sure that we're not losing contact with the patient? If we're rushing through our clinic and we don't close the loop on all his follow-up subspecialists, then we're just setting ourselves for the readmission, which defeats the purpose of having the transitional care program. And so part of this visit here is a big visit. And again, like we talked about, I think that we have to have some structural changes in the clinic so that it gives us the ability to optimize that interaction, so that ultimately what we're really doing is decreasing readmission and mortality and morbidity. And these are the codes we talked about in the objectives for the meeting. The codes that are associated with the TOC visit. This is a list of some of the requirements for the TOC visit. You know, for the moderate visits, you have to be seen within 14 days. For the medically complex visit, within 7 days. There's a diagram in the CMS booklet that talks about what goes into, how do you determine if this is a moderate or a complex, not just based on when you're seeing them, but on the complexity of the disease itself. I mean, so those guidelines are out there. We shouldn't necessarily go through that. But I think that all of us who have been doing this for a while know a complex guy when you see one. And so that's not a big hurdle to jump over. So starting a transitional care program, we kind of reviewed some of that structure. I think that most of us have programs in place because this is not a new entity. Everybody feels, at least we do on this end, feel the pressure that's coming from the system. The system is pushing us toward optimization with this, fee for service, mega data and trends are the future of what we do. We're going to be graded upon the efficiency with which we do things. And CMS is collecting the data. And so, I don't shy away from that challenge. I think that, I can think of the days when we had the luxury to be sloppy, but I don't think that exists anymore. I think that, they're asking us to do some things that are doable and actually things that we probably all want to do. The steps for a program: query the discharge, use hospital shares, the database. Again, we're fortunate in that our Epic system does not merge or share data with the Allscripts system that they use at Jefferson, but we have access to it from every place. And so we don't necessarily have technical problems with sharing data. We do have problems sometimes getting hospitals that don't have compatible EMRs. And so we can, the shares program, which is available in Arkansas, you can access a lot of the information. And so the availability of healthcare information in the acute setting is available through both Epic and Allscripts. 48-hour call system, post-discharge, we've talked about that. Create the resource network. We are challenged with everybody at UAMS with staffing. And so our ability to staff these programs up depends on the budget, depends on what's going on at UAMS, our clinic nurse staff, you know, when we rotate people off because we don't have enough people that day. But when those kind of things happens, it affects our ability to track patients. And so, you know, you can't necessarily say that you're going to optimize this and have control over those financial barriers. That's not something that we can have input on. But we can do the best with the resources that we have. And so I think that should be a conscious effort sometimes to say we're going to work short. And when we work short, we just have to do a better job with less. The appointment, moderate complexity, severe complexity. Again, the diagram is in the CMS book, and then we can review that in conjunction with the 7 and 14-day visit. And then outcome tracking. And outcome tracking, I think for us is very important. We have engaged with the IT department at Jefferson Hospital, and we are working on developing ways to track diseases by physician. And at the end of this presentation, we'll talk, we have some 2-year data that tracks CHF, COPD, and those kind of things. But I think going forward for us, you know, if we collect the data and review the data, then I think that the data can drive the change. And so we just have to know where we need to have, where there's room for improvement, what the trends look like on what we have done so far, and continuously monitor and manage that as a TOC program. And I think that I'm optimistic about our immediate future, because I think that as the technology improves and health and EMRs become more compatible, then we have the ability to track people through the system easier. And when we can track them easier, we make fewer mistakes. And so if I know what your med list is, even though down you're in Warren or CrossFit or Dumas or wherever, and I can get to your EMR and I know what the last guy who saw you thought about your heart, then we can make the appropriate adjustment. Here's our team. Tanya Hawkins, our care coordinator, Autumn Brown, Ariel Porter, Dr. Tir Monacetti, who's sitting back there. But this is probably just a picture of the guys that we had. Everybody, we recruit everybody that we can to help participate in this program. And that includes all the residents and all the staff, because if everybody's conscious of the fact that we're tracking people, then we call upon them to input the system. Our discharge volumes for 2022 by quarter. And so it looks like, you know, we're 225 average maybe per quarter. Again, we're going to track that out over time. There's you know, we looked at the post-COVID numbers and they were pretty high. Particularly, we had that Delta variant, whatever that variant was post-COVID. We had a really big spike after that. And so our admissions were up for various reasons, but the ability to track data is valuable. Another thing that we use that's in the EMR and it's also in the CMS outline for transition to care is some way to identify patients at the door who are high risk. So there is a scoring system, multiple scoring systems that you can look at when you see the person in the emergency room, which will give you a clue that this is a high risk readmission patient. You know, but usually those high risk readmission patients are usually the ones that we used to talk about. Those are the high mortality morbidity ones. So that's kind of those lines kind of cross nicely. So, you know, the 75-year-old with bad heart, ESRD, diabetes, hypertension, peripheral vascular disease. Whatever scoring system you use, he's a high-risk guy. But you know that intuitively. There are scorecards that you can use to integrate into your program that will give you a numerical value. But again, part of the value of doing a residency for you guys residents in here is that, like we talk about, you know that intuitively when you walk in the room. You know, you walk in the room and go, oh, now this guy looks like something. Readmissions. This is kind of what we were talking about, the scoring system. This is the one that is in our system, our script system at Jefferson. And so it looks at these things and gives it a numerical score, and then that's on your face, that's on your ER evaluation sheet. More of the same. Oh, I'm going back here. Okay, let me go this way. Forward, 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 forward. Okay, good. We're getting close to you. We're getting close to where you are. Okay. MedRec. This is a big one. This is a big one that we all have to pay attention to. And it's not, and it's for all the reasons that we talked about, this area is fraught with potential for error. Multiple doctors, multiple specialties, the transition of care from the hospital to the clinic and from the hospital to the nursing home. Because in our group, we also look at what's my readmission rates from the nursing home. You know, we sent somebody to the nursing home in 48 hours later, they're back in the emergency room because nobody said, we didn't send them out on diuretics, or they didn't have an inhaler, or they didn't have their insulin wasn't adjusted. But all those are little things that they actually lead to enormous cost when you add up the cost for readmission. So small errors end up in that $26 billion you guys saw on the bottom of that. Small things across the country add up to a lot of money. So our challenge is to minimize the small things. Discharge summaries within 24 hours. See, I can't see the guy back in the clinic in 7 days if I don't have a good discharge summary in a MedRec. And so even though all of us are busy, I think the challenge for transition of care, minimizing mortality, morbidity, and readmission is that we have good discharge summaries. And that's not just on the interns, by the way. That's on the team. That's on the whole team. And when the interns struggle, I want the senior guys to step up. Okay. What does it say? Oh, the things that are required for the discharge, reasons for the admissions. Excuse me, you guys, part of my screen is blocked. Significant reasons for readmission, the significant labs, all those things should be part of the discharge summary. We don't have to go through all those. I think that everybody knows kind of what those things are. These are the things that you would like to see if that person is coming to your clinic. If you're the TOC guy getting the visit. So you don't want to walk into the room being uninformed about a complex patient who was just in the hospital. So as our challenge is to make sure that our colleagues are provided with that same kind of information. Ready? And now Dr. Autumn Brown is going to give her section of the presentation.
Hello guys, my name is Autumn Brown. I'm the clinical pharmacist here at South Central. And my role with TOC has kind of evolved and changed quite a bit since we started in like 2017, I think. At first, I was responsible for doing MedRec for all of our patients and trying to make the 48-hour phone call. But as you all know, we have 27 doctors and only one pharmacist at every site. So deciding how much time I should spend on this was really important due to constraints on, it was taking up my whole day basically. So we recruited one of our LPNs to start making the phone calls, and I became available kind of on a PRN basis to her when she had questions about the medications. But then when she retired, we recruited our RN, who we'll talk in a little bit, and we decided to revamp the program about a year ago. And since then, our census has changed. So we looked at our discharges. We used to discharge on average about 6 to 7 patients a day. So you can imagine how much time that was taking. Our census is much lower the last year or two. We're only discharging like 2 to 3 a day. So that's a much more doable number for me to spend every day trying to track. So I now do a detailed discharge MedRec for each patient. I then document or If I have any questions, I contact the discharging physician, have them clarify things, send orders they may have forgotten to send. And then I pass the final medication list along via document in Epic to our care coordinator before she makes the discharge phone call is the goal. So that way she has the exact information and any questions that we may have about meds or discrepancies, she can go ahead and ask the patient for me so that I'm not having to do that phone call. And of course, discharge metric is very important. It's a quality metric that a lot of payers are looking at. So there is a quality code, not associated with payment, but I do bill the 111F when I complete the med discharge metric. And since I started being more heavily involved, I decided to query about 35 patients that I went through their discharge summaries, looking for medication reconciliation errors. And in those 35 patients, I found 30 errors. And you can see kind of they're all over the board. But the biggest, and that's almost 1 error per patient. And so the biggest were failure to resume usual treatment at discharge. So just not taking the time to realize, okay, hospital formulary was lisinopril or losartan, but the patient at home was on olmesartan or enalapril, for instance. So that was a lot of the errors. But there were many other errors too, duplications, missing prescriptions, meaning the doctor didn't realize this was a new start by the discharge, so they forgot to send a new prescription for it. And there were interactions and things like that too that were caught. And so since then, we decided to institute a daily discharge round. So not only the physician meeting with the inpatient team to discuss discharge, but now they're also required to spend time talking to us and the outpatient side about what they're going to discharge these patients on. So I can be more proactive and ask them questions and clarify the med list before the patient leaves and remind them, hey, this is a new meds in the prescription. Start meds to bed orders now so that the patient can leave with these medications. And I haven't done a second query to see if our discharge summaries have improved, but in my observation, they've definitely gotten a lot better and there's been a lot less errors the past couple months since we've started doing the daily outpatient discharge rounds. And now I'll let Tanya come up and tell you about the care coordination side.
Good afternoon, everybody. My name is Tanya Hawkins. I am the RN care manager and I am responsible for care coordination. Care coordination begins prior to the patients being discharged from the hospital. As Autumn and Dr. Wright mentioned, we have multidisciplinary rounds every day and we discuss patient discharges. Okay, now, so I'll back up a little bit and I'll just say that we all attend multiple disciplinary rounds every day. We discuss patient discharges prior to them being discharged from the hospital. In the event that that patient has some special circumstances or there's some special needs that need to be addressed prior to the appointment and during the phone call when I make the phone call 48 hours after discharge. When I make that phone call, I'm just basically finding out how they're feeling. That's how I start out. I find out if they understand their discharge instructions. If they don't, we go over those. Find out if they have their medications. If they don't have them, then I'll find out what the problem is and try to figure out a solution. So another thing that I do is I schedule appointments for them. So if they have not had time to contact the office or it wasn't done before they left the hospital, I'll go ahead and schedule that follow-up appointment. And I even go down during the appointment sometimes, meet the patient and kind of so that they can kind of put a face to whoever they're talking to, because we get a lot of callbacks. A week or so prior to the appointment, if they're having problems, they're not feeling well, they'll call me back. And then we address those issues during that phone call. Our flow kind of shows you how we take care of our patients when they are discharged from the hospital. I'll print out what we call a TOC packet, review the documents. And if there are problems, when I call the patient, I'll refer them to the pharmacist if it's a medication problem, and or the staff, the chief resident, if there are problems with any other problems that are not related to medication. So here I'll decide, or we'll decide if the patient has the appropriate resources. We'll decide if that patient may need a behavioral health referral. And we're also looking at these patients to add to our chronic care management program. A lot of the patients who have been readmitted over and over again for the same issue, we're also reviewing to check to see if they meet qualifications to be added to some of those pathways. A lot of them have been added to our diabetic pathway, and a lot of them have been added to our hypertension pathway. So back to the TOC packet. This cover sheet is the first form that the patients that I put in that packet. And this cover sheet has the patient's name, the appointment, date and time, the physician that they're scheduled to see when they come in for their TOC, the admission date, discharge date, and the date that I initially made the TOC follow-up call. At the bottom, you'll see that there's billing codes and just some useful information that may help the physician during the visit. The packet, I'll go ahead and get a packet ready. The next item in the packet will be the physician discharge summary, the history and physical, any consults. So if any specialists were consulted and saw the patient while they were in the hospital, those will be included. And I also include a nurse and discharge summary. And the reason that I do that is because I'm actually able to see what the patients are discharged with. So we can kind of review any problems that they have or anything that they don't understand. Now, sometimes that may take 15 minutes. Sometimes that may take an hour. But as I said, as I mentioned before, if any problems are reported during these phone calls, I engage the team to help resolve them.
Thank you. Ms. Khan, thank you. And so what our last and closing slides, this is just an example of some of the information that we've been able to get from Jefferson Hospital, from what our activity over the last year. I think this goes to quarter number 3 of 2020. And for this one, that red line down the middle is our trend. And this is an all diagnosis code, all diagnosis admission rates. We're in green. The blue line is premier data that's sorted by hospitals that are our size. And so this is kind of the mean or the average. And then our performance is there in green for all admissions. Same thing, this is heart failure data. And you see how up and down this is. I want to track the data, but I'm not impressed by the spikes and curves, because sometimes I think the numbers are small enough where it's not really representing the trend. If I had to look at anything, I'd look at the red line and tell us that in general say that I have a downward trend in my readmission rates for congestive heart failure. The one that does get your attention though is our actual experience in green is all over the place, as you can see. But you see that the trend in the red line tells me that, we have a problem with COPD. And so one of the things that we're talking about is post-TOC, we still have a captive audience. What can we do after that first visit to track these people longitudinally going forward? And so we have tracks that we put people in the diabetes and hypertension and those chronic care tracks, so that we're starting to integrate our TLC program into our chronic care tracks that we follow in the clinic, so that we can not only see them in that period around the hospital, but then going forward, at what point do we have to do some kind of evaluation in their outpatient status? And so, like Tanya says, people call in and identify themselves as they're having problems. You know, if we can intervene at that point while they're still at home, do we prevent a readmission? If they identify themselves, we're going to follow a certain number of them because we've put them in tracks and we're going to make phone calls. But this slide tells me that we just need to create a one for also for COPD. And again, stroke, diabetes, and hypertension. Again, I think that the ability to track your data is a way that you can modify your TLC program to try to focus in on areas where you need improvement. And the thing that stood out to me from the slides that we just reviewed is that we're kind of losing control of the COPD group. And so our effort right now is going to be directed at that group. And here, this is a slide that kind of talks about that. There's the integrated chronic care management pathways. So in summary, poor transition of care leads to high readmissions. Transition of care management codes include the 99495 and 99496. Refer to the CMS guidelines to help establish your own program or get ideas about improvement of your program. Query your local hospital about the establishment of readmission rates, and meet with your team quarterly to discuss issues and areas for improvement. Thank you very much from the UAMS South Central. Does anybody have any questions?
Dr. Wright, you've got 2 questions in your chat.
Uh-oh. Autumn.
How about if we just read them to you?
Okay,
How's that sound?
that sounds good.
Okay, great. If you could rank what you would like to see improve statewide in TOC, could you give us your number 1 and number 2 dream, like, for an example, and the implementation of an EHR that can be used statewide by all facilities?
Yeah, I think that's a big one, because I think that one of our big areas of concern is medication. And so if we could have an EMR that we had accurate information about what people are taking when they're actually ill, or what they're supposed to be taking when they're actually ill, then it would help us then formulate a plan to get them through that hospitalization. So my number 1 thing would be, if we had some way to accurately track and monitor meds. And I think our ability to do that has improved tremendously. And number 2, this is okay, compliance, but I know I can't work on that. But if I could improve, if I had a wish list, I would improve compliance. And to that end, it's patient education. So I think that my fall off with compliance is a function of my ability to educate the patient, because I don't have that many people who are willfully non-compliant. I think that they're non-compliant out of not understanding. And so it's on us to make that better.
Right. Those are great answers. Thank you.
Mhm.
We still have work to do in those areas. And also, that kind of to follow up with the EMR, do you have any idea how long you think it will be before we have something like that is statewide?
Yeah, I think it's going to be federally mandated if I had to ask. But I think that's coming, but I don't have any idea. I think this whole system is going to be crunched down to, they're going to have requirements of the system. But I don't
Right.
know when they're going to do that.
Okay. And then our last question that we have, for your med reconciliation,
Yes.
we had some curiosity as to do the providers receive some type of feedback? The individual providers privately receive feedback as to areas where they, where the mistake was made, where
Yes.
improvement could be done.
Yes, they get feedback continuously all the time and sometimes with the taser.
Okay, well, that's enforces learned behavior, right?
Yes, it does.
Okay, well, that's great. Thank you.
Okay.
We've really enjoyed this from your team. It's
Okay,
been very, very good. And I believe that's all of the questions that we have for
okay,
you right now. Thank you so much for sharing.
okay. Thank you very much.
Thank you.
Bye-bye.